So I know you laid a lot of foundational groundwork with gastrointestinal conditions such as peptic ulcers and GERD and appendix. These I do expect you to be familiar with, but there won't be so specific questions. If you're just familiar with those conditions, you should be just fine for the test. Because they're conditions I really think that you're pretty familiar with. So for this content, I really wanted to focus on gastrointestinal medications because you may be less familiar with these since you're in acute care. Additionally, there will be a short video on diverticulitis and diverticulosis that you'll need to review as well. But outside of that, if you just know generally what GERD is, signs and symptoms, generally signs and symptoms of appendicitis, which I'm sure you're all familiar with, um, and generally the signs and symptoms of peptic ulcer, you should really be just fine on the exam for all of those disease processes. I really want to get into the pharmacology and more how we treat them than the disease processes themselves, because I figure you have to learn what the disease process is in order to treat it. So that's what I'm focusing on for that part of this exam. So the emetic response is pretty much received by two areas in our brain, the vomiting center and the chemoreceptive trigger zone, or CTZ. Signals are sent from the locations indicated here, and depending on where those signals are sent from, many different medications can actually help us prevent vomiting. So for example, the vestibular apparatus of the inner ear. Um, a medication that may help us with that actually is something that will help with motion sickness. In this case, like meclizine or Antivert over the counter, it may be called Antivert. That actually can help with the vestibular apparatus, which originally would send a signal to the vomiting center invoking emesis. But because this medication works to stop that signaling, it prevents vomiting. So based on whether and where the information is being sent from, whether it's sent to the vomiting center or chemoreceptor trigger zone, different medications help us with each. So categories of antiemetics. I would expect you to know serotonin antagonists. The prototype med is ondansetron or Zofran. Dopamine antagonist. The prototype med is prochlorperazine or compazine, or promethazine, which is phenergan. Also remember with this, Reglan is a dopamine antagonist, but it also is a GI stimulant, so it's kind of special in that category. Metoclopramide, sorry, Reglan, I'm sure you guys say that better than me. And the cannabinoids, which is basically in the family of marijuana. Anticholinergic, which is scopolamine or scopolamine patches, and antihistamine, which is Antivert or meclizine. So as we go through here, I've pretty much named the ones I would expect you to recognize on a test. Cannabinoid, I will probably just refer to it as cannabinoid. So one more time, what is the prototype med for serotonin antagonist? Go ahead and say that. Ondansetron, which is Zofran. What are the two I expect you to know for dopamine antagonists? Prochlorperazine or compazine, or promethazine, which is phenergan. The other one we have to know is Reglan, which is a combination med of a dopamine agonist and a GI stimulant. The cannabinoids basically know that marijuana is an option, and that's a good option for some patients. Anticholinergic, which is our scopolamine, and antihistamine, which is our meclizine or Antivert. So we'll talk about each one of these groups. While I'm here, I don't think I have a special slide for the cannabinoids, so let's talk about those briefly. Cannabinoids are really good for patients who may have failure to thrive. They're really good for HIV, Hep C patients, older adults, because as we know, they not only help with nausea, maybe post-chemo, but they also help with appetite. So that's one of the benefits you get from cannabinoids. They help with nausea and increase appetite, which some of the others may not do. The anticholinergic, let's think of that as, of course, drying everything, dry eyes, dry mouth, unable to urinate, and constipation. But scopolamine patches are the patches that you see behind the ear. Usually they'll be 2 to 3 days behind the ear. You will see these used for end-of-life patients to dry up their secretions, and for certain people who may use them to travel. But most of the time I've seen them either scopolamine drops or patches for end-of-life care. And then antihistamines, as we talked about earlier, they actually work very well, sending a signal basically from that inner ear to the brain, but work for motion sickness like meclizine or Antivert. These are the ones you want to take before you travel. So I think those are the key points about those, and we'll go on to look at the serotonin antagonists. Serotonin antagonists, as I said before, ondansetron, which is Zofran. We talked about all of this in the previous slide. Chemotherapy, pre-treatment, 30 minutes before. Adverse reactions are really limited. Maybe some headaches, some dizziness, some diarrhea, but really limited with these medications. It's one of my favorite medications. Not based in evidence-based practice, but I have seen in my practice light-skinned, especially women like myself, do better with Zofran than they do with the dopamine antagonists. It is category pregnancy B. Dopamine antagonists, again, block that dopamine receptors at the CTZ, decreasing the need to vomit. These work, again, with chemotherapy, but we tend to like Zofran better. These, again, should be administered 30 minutes before chemotherapy treatment if you're going to give it for that. Side effects are those extrapyramidal symptoms. Again, big risk with these, only a small percentage of the population, but very devastating to those that experience them. Benadryl, if they do experience extrapyramidal side effects. Hypotension and sedation with these. Need to use cautiously in patients who have high seizures, other medications that may increase their chance of extrapyramidal effects, urinary retention. These are contraindicated in narrow angle glaucoma. Use cautiously in older adults and children. These have unpredictable behaviors in both of those populations. This is just a little cartoon for compazine, so if these help you and you can picture these, feel free. It gives you some signs and symptoms. So now we're going to be looking at Reglan, and Reglan is slightly special because it not only blocks the dopamine at the CTZ, but it augments the action of acetylcholine to increase GI motility. So it makes these really good medications for post-op nausea and vomiting. It decreases that feeling of nausea and vomiting, but it also increases GI motility, which is what we want post-op. We do not want to give these to any patients who have unknown abdominal pain, any GI bleeding, any perforation, any bowel obstruction, because of those actions to increase GI motility. So we really want to stay away from Reglan if we don't know why they're having abdominal pain. Again, these do come with a chance of extrapyramidal symptoms, extra sedation, sometimes diarrhea because of that action on the dopamine. Interact with anticholinergic and opioids. These also are used to promote gastric motility with G-tube feedings. So just keep that in mind as well. This is just a cartoon with Reglan, so you can read through that if that helps you remember. Other antiemetic medications, we pretty much talked about cannabinoids, glucocorticoids, please don't worry about, and anticholinergic are really the best for motion sickness. Other nursing interventions, please include these when somebody is nauseated: fresh air, slow deep breathing, carbonated beverage, so that's like our Sprite, tea, crackers. Herbally, ginger is a natural antiemetic. Aromatherapy, such as peppermint. Um, I put the alcohol here because that is alcohol wipes, so alcohol pads. Um, One of the tips I got from anesthesia, and actually it is based in evidence-based practice, they don't exactly know the mechanism, but if they are post-anesthesia, it really only works on anesthesia patients and they're nauseated. If you have them smell an alcohol wipe, occasionally it will take their nausea away. So just realize that's one of the first things that you can try before you even push a medication. And then acupuncture, high flow oxygen. Make sure we're hydrating these patients and providing frequent oral care. Make sure these patients who are avoiding alcohol, make sure that they have bowel sounds, make sure that they don't have abdominal pain, that the vomiting is not from something else that we have missed. Make sure they're properly hydrated, so watch their I&Os, and of course their vitals, make sure they don't get too orthostatic or decrease blood pressure. So we need to monitor their electrolytes as well. Emetics, basically Ipecac. Syrup of Ipecac since 2003 is no longer recommended. Really, that's all I need you to know about that. Treatment of ingested poisons, just remember we always call poison control. And we always like to do the activated charcoal. Basically, it acts as an absorbent. If it's ingested, charcoal is ingested in 30 minutes of the poison, 90% is absorbed, 37% after 60 minutes. So looking at histamine receptor antagonists, anytime you're talking about any kind of medications as we move forward that treat any kind of acid secretion in the stomach, it's important to know that the patient needs to consult with a primary care physician. This became a problem when they were prescribed over the counter because patients would just go in and get them, and actually it covered up signs and symptoms of things like cancer that they were not seeking treatment for. So they should only be on these acid reducers if their primary physician knows that they're on them and why they're on them. So if they've been diagnosed with GERD, gastroesophageal reflux disease, then that's fine. We understand why they're taking them. So the doctor can monitor those and understand if there are any changes in their signs and symptoms other than those GERD symptoms. The action of histamine receptor antagonists is to suppress the secretion of gastric acid by blocking histamine 2 receptors. So these decrease the acid secretion in the stomach by blocking the histamine 2 receptors, which help excrete the acid in the stomach. Adverse reactions from these, again, headache, nausea, vomiting, nothing really stands out. The thing I want you to remember with these can actually cause decreased libido and impotence. So remember that these can cause those issues. The primary prototype med is ranitidine or Zantac or famotidine and Pepcid. So put those in your head as H2 blockers. Take with or immediately following meals. The onset is 30 to 60 minutes. Peak 1 to 3 hours. Duration 6 to 12 hours. Pregnancy category B. Beware when you're taking these with warfarin and phenytoin. Proton pump inhibitors irreversibly inhibit the proton pump. So the hydrogen potassium pump that actually excretes the acid in our stomach, it irreversibly inhibits that. So realize this is the biggest decrease of acid we can provide. This is that medication that literally blocks that. This is once a day dosing. The most common types I want you to know are pantoprazole, which is Protonix, and you will see these given in the hospital IV push. You have to reconstitute with 10 mLs of fluid, and you will push these in the IV to prophylactically treat ulcers, so to prevent ulcers because the patient's in a stress state. The one I expect you to remember over the counter is omeprazole or Prilosec. These are highly, highly protein bound, so just realize that when you're dealing with them, and they're pregnancy category C. Proton pump inhibitors. Prototype, omeprazole or Prilosec over the counter, and pantoprazole or Protonix IV push in the hospital because our patient is in a stress state. So it's to prophylactically treat them from getting an ulcer. Let's talk about peptic ulcers. There's esophageal, gastric, or duodenal ulcers. Common causes are GERD or H. pylori bacteria. Use of NSAIDs can also increase our chances of developing an ulcer. Hypersecretion states. Some people are pre-genetic, have exposure, genetic predisposition for ulcers, and cigarette smoking actually increases our chances for developing peptic ulcers. Again, we pretty much went over this. Defense factors against peptic ulcers are the mucus, bicarb, blood flow, and prostaglandins. And if you remember, NSAIDs actually decrease the mucus and decrease the blood flow and decrease the prostaglandins. So pepsin does the same thing along with smoking. And H. pylori is, of course, the invasion of bacteria into the stomach. Gastric acid production just goes over how we produce acid, and you notice the hydrogen potassium pump there, pumping in and out of the acid of the stomach. Anti-ulcers. So let's talk about anti-ulcer drugs. Most people will be given at least 3 drugs. One will be either a histamine blocker or a proton pump inhibitor, one or the other, not both. Then they will be prescribed an antibiotic. Bismuth sometimes is prescribed as well, which is Pepto. And antacids, which are acid neutralizers, are often prescribed. And a pepsin inhibitor, like Carafate, that coats the interior part of the stomach, which especially helps if you already have an open area in the stomach. That Carafate can coat that. Now, remember, with antacids, we don't want to give any medications within an hour of them, either before or after them. And the Carafate that coats our stomach, we really want to limit fluid intake, food intake for at least 30 minutes to an hour after we consume it, because it coats the stomach, and if we're just going to consume a bunch of liquid after that, it will just flush out the stomach and it won't help us coat the stomach that we're trying to get the protection from. So an antibiotic is prescribed. Anti-secretant agents like H blocker, a proton pump inhibitor, a mucosal protectant, which is Sucralfate or Carafate, an antacid or an acid neutralizer. So we want to eliminate the symptoms, promote healing, prevent complications, and prevent reoccurrence. Antibiotics, these are probably the most common ones that you will see to treat any kind of ulcer. Make sure with Pepto that you warn them that they may end up with a black tongue, black stool, or bleeding, because don't forget, Pepto-Bismol actually has aspirin in it. So Carafate coats the stomach. Again, it says here an hour to 2 hours between other drugs and meals. I think in one of your books it says 30 minutes, but we'll go with 1 to 2 hours because you do want that benefit of it coating the stomach. Cytotec is a replacement for the blocked prostaglandins in biosynthesis. This is used in ulcer prevention during NSAID usage. So it is pregnancy category X, and I probably will not ask you any kind of question on that on your exam. But I would know how Carafate works for sure. So we want to make sure we avoid tobacco, lose weight, don't use NSAIDs, sit upright, don't eat before bedtime, wear loose-fitting clothing, decrease our alcohol intake, avoid hot, spicy, greasy foods. It's better to eat in small meals than larger meals in one setting. Just non-pharmacological measures to help us with GERD and ulcers. Antacids. I may ask you a few things about antacids. 1 to 2 hours after meals, it says 3 here, that's a little extreme. 1 to 2 hours after meals, don't give with any medications because it interferes with the absorption. The 4 most common types are aluminum, magnesium, calcium, and sodium. Sodium bicarb, you don't see that much used as an antacid. So just realize it's in the antacid family. Most of the time when we see it used is in acid-base imbalances, especially towards the end of a code. They may go ahead and throw some sodium bicarb at them to try and rebalance their acid-base balance. Most common ones are aluminum and magnesium kind of combinations. Realize aluminum combinations or compounds cause constipation, magnesium causes diarrhea, and calcium causes constipation. So just make sure you kind of put that in your head. Aluminum also can cause white streaks on the stool, so sometimes that's concerning for patients. So we want to warn them about that. Any sodium kind of containing compounds are not good, of course, for people who have hypertension. So that's about all I would ask you about any antacids. Just realize it's an acid neutralizer, so all it doesn't change secretion, it just neutralizes the acid in the stomach. I think we pretty much went over all of this. The only additional thing is the enteric-coated medications, a good point to think about. These may prematurely release if they're taken with antacids. First of all, don't give any meds with antacid. It changes how they're absorbed, right? Don't take calcium carbonate or milk or other foods high in vitamin D when you take antacid. Changes how it's absorbed. But enteric-coated medications, because they're enteric-coated, that coating does not break down until it hits an alkaline environment. So we expect it to hit the small intestine and then break down, as opposed to the stomach. That's why aspirin is very difficult or hard on the stomach. They enteric coat it and it doesn't break down until it hits the small intestine where it starts breaking down that coating. So it bypasses the stomach, so we avoid stomach upset, okay? But when we have enteric coated medications and we take them with an antacid, the antacid makes our stomach a more alkaline environment, therefore maybe breaking down those enteric-coated medications in our stomach when they should be broken down in our small intestine. You guys can read through the criteria for constipation. So really, what defines constipation? So I just look through those and be familiar with those. Causes can be drugs, obstruction, pain. For instance, pain, like if you're post-op and you're really not wanting to push hard to push out your stool, you just leave it and you become more and more constipated. Depression, because you're not moving around. Endocrine system, of course. Contraindications for kind of treating constipation would be abdominal pain of unknown origin, possible appendicitis, diverticulitis, ulcerative colitis, pregnancy. Indications for laxatives, painful elimination, hemorrhoids, episiotomy. If they're post-op from an MI, we really want to prevent that vasovagal response, so we want to keep their stool nice and soft. Elderly with weak abdominal muscles may need these laxatives and correction for constipation, which could also include opioid use, or they're in the hospital and they're put on morphine and now they're constipated, or lack of moving around, and now they're constipated. So these are treatments for constipation. There are I want you to remember 4 different kinds of laxatives. There are 3 different groups. Bulk forming laxatives, surfactants, stimulants, and osmotics. Those are the 4 that I want you to remember, and we'll discuss prototypes in each one of those. We'll also discuss the groups as we go. Group 3, remember you produce soft stool in 1 to 3 days. Group 2, semi-soft stool 6 to 12 hours. Group 1, watery stool in 2 to 6 hours, and those are much more aggressive. So group 3 laxatives are bulk forming laxatives and our surfactant laxatives. Bulk forming, our psyllium is our prototype. Surfactant would be glucosate. Okay? Bulk forming basically just adds bulk to your stool. Increasing the amount of stool increases the peristalsis. What you need to remember with bulk forming laxatives is you need more water intake. If you don't have enough water intake, all this results in is an obstruction, an intestinal obstruction or an esophageal obstruction. So make sure you're consuming enough water with these. Surfactant laxatives actually pull in not only water but fat into the stool. So it actually allows it to penetrate the stool, allowing it to become softer and better able to be passed. So bulk forming, psyllium, surfactant, glucosate. Bulk forming pretty much just bulks up the stool. You need water to do that, but it doesn't pull in water, so don't get confused. It actually acts more like fiber and bulks up the stool. Okay? The surfactant actually pull in water and oil into the stool. And here's just a picture of Metamucil or psyllium if you want to take a look at that and kind of see how it works. Group 2 laxatives, these are our osmotic laxatives. These do pull in water into the stool. Okay? And then the stimulant laxatives. These actually stimulate the nerves to increase intestinal motility. So our osmotic laxatives are milk of mag, polyethylene glycol, or Miralax. So these are ones that we'll see residents given after 3 or 4 days of lack of a bowel movement. They work much quicker than group 3, but they're a little more aggressive. So we prefer to use group 3 as a group 2, but when we need to, we'll pull in group 2. Stimulant laxatives actually can increase the chance of becoming dependent on laxatives. So if there's one group that will cause dependency, it's the stimulant laxatives. These are like Senecot, X-Lax, Bisacodyl. These are more aggressive, but oftentimes you'll see them given in combination with maybe a bulk or maybe a surfactant. But stimulant laxatives have the highest risk of forming dependency on them. So you need them to go to the bathroom. So we try and steer away from these as much as we can. The least addictive would be the bulk forming laxatives. You can use those all the time. They're very natural. They just add bulk to the stool and don't form dependency. Here is just milk of mag. I like this saying, milk of mag in the AM for BM in the PM. So watch for abdominal cramping. Milk of mag also helps keep burning under control in the stomach as well. Group 1 laxatives are much more aggressive. These are osmotic laxatives in high dose. So these are what you see when you're doing a bowel prep. Okay, so go lightly. These are large volume. You want the person to really be, their system to be cleaned out. Castor oil, which acts on the small intestine. Castor oil is actually pregnancy category X because of the risk of aspiration. Use in caution in renal disease in combination with diuretics, ACEs, and ARBs just because of the fluid imbalance that can come with these. So group 1 laxatives, really to go lightly. We're going to be very aggressive about really flushing the system of the patient. Usually these are Treatments for patients who are going in for a procedure or a scan. Laxative abuse, again, the most abused are the stimulants, okay, and the least are the bulk forming. Make sure that we're educating our patients that they shouldn't be relying on laxatives to go to the restroom. So this becomes a problem, especially in older adults. Diarrhea, basically treat the underlying cause, make sure that we're supporting them through their diarrhea, make sure we're checking their electrolyte balance, making sure we are checking their vitals, blood pressure, pulse, making sure they're not getting too dehydrated. Antidiarrheals like loperamide are opiate containing, so these oftentimes do have opioids with them because that slows GI motility. Initially, they didn't put them in combination with anything, but now they're in combination with things like an anticholinergic, okay, like atropine, because if you don't combine them, what tends to happen is they're too addictive. So once they started figuring out that people were getting addicted to the opioids to control the diarrhea, they actually added the anticholinergic to add those drying effects, so it makes it really unlikely that they will overdose or become addicted to them. So basically, nursing implications: monitor the patients, assess them, especially if they're having abdominal pain of unknown origin. Make sure we're properly treating them with the correct medication, not covering up those signs and symptoms. Patient should, our goal should be to have normal bowel movements, maintain fluid balance, making sure the INOs equal out, making sure we don't have electrolyte disturbances, evaluate until the diarrhea is relieved and adequate hydration takes place. Make sure that you teach them properly. If they're on an antidiarrheal, they shouldn't be on it for more than 2 days. Make sure that they maintain, again, the fluid intake and electrolytes. Make sure that they're eating proper food. So we want bland food, clear liquids as they're coming out of the diarrhea. Making sure that they prevent diarrhea to begin with by washing food, washing hands, avoid any local water if they're traveling, chew food well, and making sure to avoid any overuse of laxative products.